Prasad Eye Institute in Hyderabad, India. Professor, I think you will be thankful when we tell you that the heat index here in Manila reaches 41 degrees Celsius. And outside Metro Manila, the heat index has gone up to as high as 51 degrees Celsius. So it is a good thing that you are with us only virtually. Your topic, corneal infections, is still very common in our country. Definitely, most, if not all, of our members will find the knowledge that you will share with us very useful. To our PAO members who are tuned in, the long wait appears to be far from over. We appreciate your patience as we closely coordinate with the infectious disease experts. Please know that your safety as well as your patients and your families come first during these challenging times. Let me take this opportunity to thank the organizers of today's distance learning program webinar. It is the result of the close coordination and cooperation between the Philippine Cornea Society, the PAO Committee on Continuing Education in Ophthalmology, and most especially our talented technical team. Welcome and thank you.
Thank you, Dr. March, the President of the Philippine Academy of Ophthalmology. I was tasked to introduce our guest speaker. Our guest speaker really is no stranger to the Philippine ophthalmic community. His gracious wife were our guests sometime in 2015 during our annual PAO meeting. In that meeting, particularly in the forum hosted by the Philippine Cornea Society, he gave us a wonderful 7 mini lecture series on the general heading of Global Trends on the Diagnosis and Treatment of Infectious Keratitis, where we benefited from his fine distillation of the recent advances on the topics discussed, coupled with a crisp clinical practical application on the diagnostic and therapeutic approaches to the diseases. He was again in the Philippines back in 2016, this time as our guest at the during the 30th founding year of the Department of Ophthalmology of the Department of Health Eye Center, where he talked about uncommon corneal infections, advances in the management of fungal and acanthamoeba keratitis. Even during his early days in practice, he was very keenly interested in improving quality of education. In addition to his being director of education at the LV Prasad Eye Institute, he participated in several ICO-sponsored education for educators program, both at the national and international levels. He had also attended the program for educators in health conducted by the Harvard Macy Institute in Boston, USA. He has been a member of various national and international ophthalmic communities, including the American Academy of Ophthalmology and the Asia Cornea Society. He is on board the International Joint Commission for Allied Health Personnel and the ICO Subcommittee on Allied Health Education. He has been a recipient of various international awards, prestigious among which were the Senior Achievement Award from the American Academy of Ophthalmology, which he got in 2013. And in that same year, he was awarded the Outstanding Achievement Award by the Asia Pacific Academy of Ophthalmology. Dr. Prashant has authored 191 scientific publications, including 9 book chapters. He obtained his medical degree in 1987 and residency in ophthalmology in 1991 from the RNT Medical Colleges, which is affiliated to the Rajasthan University in Jaipur. He completed his cornea fellowship at the LV Prasad Eye Institute and joined the organization as faculty as early as 1997. Corneal infections are really his primary interest and ongoing researches on this topic. He has likewise worked on various aspects of corneal surgery and eye banking, where he now serves as the Director for Eye Banking Services across the LV Prasad Eye Institute network in India. So ladies and gentlemen, let us welcome our guest for this afternoon, Professor Prashant Garg, who is presently the director and the Kalam Anji Reddy Chair of Ophthalmology and the Dr. Paul Dubort Chair of Cornea for the LB Prasad Eye Institute based in Hyderabad, where he serves as faculty in cornea and anterior segment diseases. Professor Prashant, welcome.
Thank you very much, Dr. Santos, for this generous introduction. I would like to thank Philippines Academy of Ophthalmology for inviting me for this lockdown symposium. It will be a pleasure to share with you some of the experience that I have gained over a period of time. The title of today's talk is going to be Controversies in the Management of Corneal Infections, and I'm sure you will find this talk useful, particularly as it deals with some of the issues for which the literature does not give us a very definitive answer, and each one of us try to make sense of the published literature in our own ways. Let me start sharing my slides. Are the slides visible?
Yes, Professor.
So as told by Dr. Santos in the introduction, I have very fond memories of my 3 visits to Manila. In one of the visits, I was accompanied by my wife, and she always remembered the days that we spent in Philippines. The churches, the memorial park, and the friendship that was extended to us by all of you, both during the Philippines Academy of Ophthalmology annual meeting, as well as the Asia Pacific Cornea Society meeting, and then when I visited Dr. Santos. So I think the Philippines Ophthalmic Society has a very special place for both of us. Let us start with this case. Have a close look on the cornea that is shown on this slide. This was a case of a 20-year-old female who presented to us with symptoms of pain, redness, watering, and diminution of vision of 2 days duration. She was a soft contact lens wearer and used to occasionally sleep wearing contact lenses. I am sure that we will not have much difficulty in making diagnosis of this condition, as well as understanding the etiology of this corneal infection. And since this is such a straightforward case where we are likely to be sure about the etiology of this case, one of the questions that comes to our mind is, should I be doing microbiology workup for this patient? And what is that additional information that I will get from this case? If we push this case to community ophthalmologists, I am sure that many of the community ophthalmologists may say that I do not have a definitive answer. I may or may not go for microbiology workup. Now, this question is particularly relevant because this is the first question that we come across with whenever we manage cases of corneal infection. But there are several other questions on which we do not have a very definitive answer. Should we be treating this kind of a condition using fluoroquinolone monotherapy or a combination of fortified antibiotics? What is the role of corticosteroids? And at what stage should I start corticosteroid? What is the role of collagen crosslinking? If it is a case that turned out to be fungal infection, should I start treatment with voriconazole or netamycin? And if this case worsen and end up requiring surgery, whether penetrating keratoplasty should be done or should I perform lamellar keratoplasty. So these are all questions that are very common whenever we are managing cases of corneal infection. Now, how many of us will like to do microbiology in a case that I just showed? Will you like to do microbiology in every one of a case that is associated with contact lens and has a shorter history? Is a question that probably we do not have definitive answer, and I'll try to resolve this question in my subsequent sections. If we look at the literature and a standard textbook, most of the publications advise ophthalmologists to do corneal scraping and subject that material to a detailed microbiology workup in order to identify the causative microorganism and also to understand the antimicrobial susceptibility if it turns out to be bacterial infection. But what does it involve? I think it involves collecting the sample using either a sterile 15-number surgical blade or Kimura's spatula, and then subjecting this material to a variety of microbiology tests, which comprise of microscopic examination of smears using variety of stain, which include classically gram stain and potassium hydroxide chalcofluoride preparation. Some of the labs also use GIMSA or GMS stains. The material is also inoculated on various solid and liquid media that facilitate the growth of microorganisms and typically comprise of blood agar and chocolate agar to facilitate growth of bacteria, sabrode dextrose agar and potato dextrose agar to facilitate growth of fungi, non-nutrient agar with an overlay of Escherichia coli for acanth amoeba. We also use brain heart infusion broth and thioglycolate broth. The laboratories that are involved into molecular diagnosis also collect sample in phosphate buffer saline. If there is a growth of bacteria, then you need to conduct antimicrobial susceptibility test using variety of method, which comprises of Kirby bar disc diffusion method and minimum inhibitory concentration measurement using either broth microdilution test or E-strip test. Now, when I am describing this laboratory workup, you all must have realized that this whole gamut of tests will require a very well-equipped laboratory, a staff that is trained to handle ocular samples, and therefore there will be additional logistics that an ophthalmologist will have to work on, and it will involve cost both to the healthcare providing facility as well as patient. And this is basically the reason that if you do a survey in community and try to find out how many ophthalmologists really treat patients of corneal ulcer using microbiology protocol that I just described, you will find that even in United States, more than 60 to 70% of the patients are treated empirically without any microbiology workup. And if you go into the developing countries, close to 90% of the patients are treated empirically. Now, therefore, there is a dichotomy. Their books and the published literature is advocating microbiology workup in each and every case of corneal infection, whereas in real life, very few ophthalmologists are using microbiology facilities for the management of corneal infection. And therefore, this question that is this protocol really necessary in each and every case of corneal infection becomes very relevant. If we ask our residents to reply that, how will you manage this case? I am very sure that most of them will say, I'll do a detailed microbiology workup. But when those same residents go into the practice, they themselves do not follow these protocols because they find it extremely difficult, both logistically as well as because of the financial reasons, to follow those protocols. Realizing this, in 2005, World Health Organization's South Asia subcommittee convened a meeting of experts on the corneal infectious diseases and took their help in trying to develop guidelines for the management of corneal ulcer that are relevant for developing world. Some of the facts that this committee took into account while formulating these guidelines were that most of the corneal ulcer in community are bacterial etiology. And most of the antibacterial agents that are used in the treatment of these cases are bactericidal. And therefore, the third fact became very obvious. That is that even though most of the community ophthalmologists are treating these patients empirically, we are able to get demonstrable clinical response in many of these patients. Only few cases that do not respond to initial therapy are then referred to tertiary eye care centers, and they turn out to be cases which are either drug-resistant bacteria or are caused by some of the other organisms that normally do not respond to antibacterial therapy. The group also took into account that most of the antifungal agents are fungistatic, and for these agents to, or for the patients of fungal infection to have the demonstrable clinical response takes weeks, often 2 to 4 weeks. And if you combine antibiotics with antifungal agents, then you are likely to lead to toxicity, and that will make the management even more complicated. And therefore, the primary purpose of a community ophthalmologist working with limited resources will be if they can distinguish cases caused by fungi from rest, then most likely they will be able to start treatment without much of laboratory workup. So what was the recommendation? The committee recommended that ophthalmologists must become familiar with the microscopic examination under light microscope using 10% potassium hydroxide. This is not very cost intensive, and if they are able to visualize fungi in a patient with a suspected fungal like clinical picture, then they can with certainty start antifungal treatment. If there are no clinical signs of fungal etiology and the KOH smear is not showing any fungal filament, then these patients can be treated with a broad spectrum antibiotics. So the recommendation committee made was that all these small ulcer, non-severe ulcer that do not have any features suggestive of fungal or parasitic etiology and on KOH smear have not shown fungal filament can be started treatment with a broad spectrum antibiotic empirical. However, all severe corneal ulcers or the ulcers that are larger, closer to limbus, associated with extensive thinning, they must be subjected to a microbiology workup. And if an ophthalmologist does not have the facility of microbiology laboratory, they must refer these patients to higher center where such facilities and expertise exist. This will save time and probably help salvage eye through initiation of an appropriate management which is based on microbiology work. In addition, the committee felt that at tertiary care centers or at teaching hospitals, all the corneal ulcer cases must be treated based on microbiology. And this recommendation was primarily because it is a responsibility of teaching hospitals or the referral centers to generate data that guides community ophthalmologists on epidemiology of corneal ulcer and the prevalence of antibiotic resistance. To exercise that responsibility, it is important that all teaching hospital or the hospital that are associated with teaching institutions and the referral centers must treat patients based on microbiology workup. So that completes our first dilemma. I will like to ask a question from panelists as to what are the proportion of cases of corneal infection that are treated based on microbiology workup in Philippines. Dr. Santos, if you can guide me on that.
Okay. In the Philippines, prior to the advent of fluoroquinolones, there were a lot of ophthalmologists who would give tobramycin because the cephalosporin are not available as ophthalmic medication, some would formulate fortified formulations of the cephalosporins to cover for the gram-positive and would use the available tobramycins or aminoglycosides to go for the gram-negatives. But with the recent advent of the fluoroquinolones, especially the fourth generation fluoroquinolones, I think most ophthalmologists are fond of using them as a broad spectrum coverage for antibiotic coverage, Professor.
Mm-hmm. But are these patients treated empirically, or the microbiology workup is commonly practiced in Philippines?
Well, for those which were referred to institution-based training programs, they're mostly worked up and given gram stains and cultures and sensitivity. But while waiting for the results of culture and sensitivity, they give the broad spectrum antibiotics. I would imagine that in provincial practices or those facilities or clinics, we do not have readily access to laboratories, that they would still give the broadest spectrum antibiotics. I think that is the practice in the Philippines, Professor. Maybe Doctors Jack Diliaco and Ruben may, because they're also in teaching hospitals, they're with the state-run university teaching hospitals, to see what their practices are.
Yeah.
Dr. Diliaco, no? May I start? So I think the practice pattern is very similar to what the professor has mentioned. No? A lot of the general ophthalmologists or non-cornea specialists or even cornea specialists not practicing in a teaching institution in a large hospital, then usually they do empirical therapy first. Microbiology, just like in the in India, it's not done routinely. But just like what you mentioned, in all training institutions, since I'm in the training institutions, and most of our cases are referred to us, and these are almost all are difficult cases, it's standard to do microbiology. Since we have residents to train, we have fellows to train, they are trained to do microbiology. That's why it becomes a standard procedure. But in the community, I agree that it is not done routinely.
And what is the primary treatment or the first line of treatment that is offered to the patients?
If the practitioner, if the ophthalmologist think it's a bacterial in origin, I think majority, almost more than 90%, will prescribe on the newer generation fluoroquinolones. May it be levofloxacin, may it be moxifloxacin or gatifloxacin. Usually this will be the first line of drug. It used to be that many years ago, before the age of fluoroquinolones, our cornea clinic gets a lot of bacterial infection, bacterial keratitis in the forms of referrals. But nowadays, they get less and less, with the introduction of the fluoroquinolones. Less and less bacterial keratitis are being referred to our center, and we are seeing more of the more advanced fungal, more advanced acanthamoeba, or those atypical types of bacteria. The usual type, like the strep and the Moraxella and the Pseudomonas, are now usually treated successfully, okay, by the either general ophthalmologist or by a cornea specialist using the available fluoroquinolones.
So, if Jessica, if you have the option of say one of the fluoroquinolone, will you still use fortified antibiotic, and what will be this scenario in which you will use fortified antibiotics?
Well, for the smaller ulcers, I do usually start with fluoroquinolone, the newer generation of fluoroquinolones, such as your levofloxacin and moxifloxacin, and then I reserve the fortified steroids. Fortified antibiotics for those cases wherein there's severe infection, those site-threatening ones, and those not really responding to the broader spectrum antibiotics.
So thank you very much. And I think this brings me to the second aspect of that there is a lot of pressure from industry on prescribing fluoroquinolones, and therefore this question of whether we should treat patients of corneal infection with fluoroquinolones or a combination of antibiotics becomes very relevant. The fortified antibiotics have certain disadvantages. Number one, these are not commercially available. They have to be prepared from parenteral formulations, and therefore they have very limited shelf life. There are issues with the pH and tonicity based on the kind of formulation that you are using. And many times, because they are dispensed in higher concentration, a prolonged use of these drugs may cause ocular surface toxicity. The fluoroquinolones, on the other hand, are commercially available. There is no issue with the shelf life. Their pH and tonicity has already been tested to be safe in phase 2 trials, and they have been shown to be non-toxic in phase 3 trials as well. The use of fluoroquinolones for the management of bacterial keratitis became popular after the bacterial keratitis study. In this study, the authors compared the clinical cure in the group that was treated using ofloxacin versus the control, which received treatment with a combination of fortified cefazolin and tobramycin, a practice that was very prevalent in 1980s or so. Now, this randomized clinical trial very clearly showed that fluoroquinolone monotherapy was as effective as combination therapy. Now, following this study, most of the cases of corneal ulcers were treated using fluoroquinolones. At that point of time, it was first generation fluoroquinolones. But because of the emergence of resistance to first generation fluoroquinolones against a variety of infecting organisms, the 8-methoxyfluoroquinolones were brought in the market. These are moxifloxacin, getifloxacin, basifloxacin, and levofloxacin. All kind of subsequent generation of fluoroquinolones were brought in the market. The developer of these fluoroquinolones thought that because of the dual mechanism of action, these fluoroquinolones are likely to develop or likely to have less risk of developing resistance. And initially, the experience was that these fluoroquinolones were effective even against ciprofloxacin-resistant isolates, specifically against gram-positive organisms. So that gave a lot of enthusiasm about the use of 8-methoxyfluoroquinolones. But of late, and substantiated both by the Asia Cornea Society Infectious Keratitis study as well as the data that we generated in our lab, we realized that countries like Philippines, China, and India are having a bigger problem of resistance even for 8-methoxyfluoroquinolone. That resistance is specifically seen against gram-positive organisms as well as Pseudomonas aeruginosa. And therefore, there the debate started. Is monotherapy with fluoroquinolone is still relevant in the management of corneal ulcer? American Academy of Ophthalmology had a debate in one of the ocular microbiology inflammatory disease symposium, and then they developed these guidelines where they made a recommendation that if you are dealing with a small infiltrate measuring 2 millimeter or so, fluoroquinolone monotherapy with one of these recent generation fluoroquinolones will be advisable. However, if we are dealing with a corneal infection which is larger in size, which is serious, then the treatment must be started with a combination therapy, combination of fortified cefazolin, which is active against gram-positive organism, and aminoglycosides, which are effective against gram-negative organism. Now, to reduce the dependence on formulations to be prepared, the recommendation was that we can have fortified cefazolin for gram-positive and add one of the first generation fluoroquinolones rather than dispensing aminoglycosides. So currently, it is advisable that we treat serious corneal infection with fortified drops. But this debate is becoming more complex if you think about levofloxacin 1.5%. It is 3 times higher concentration than conventional fluoroquinolones or the other fluoroquinolones. And therefore, should it be considered as a fortified antibiotic? Should it be considered as a non-fortified antibiotic, as the other debate that has started? We need to gain more experience as far as the clinical response is concerned with 1.5% levofloxacin, but those of us who have access to 1.5% levofloxacin probably can consider that when treating severe corneal infections. Let me now bring in another complexity in the management of bacterial keratitis, and that is, should these patients receive corticosteroid to suppress inflammation? And if so, should it be started right when we start treatment with antibiotic? Or should it be the protocol that we first treat this patient with antibiotic and then only when response to treatment has been documented that we add corticosteroid? And if so, how many days after starting antibiotic should we start corticosteroid? Can I get some response from panelists as to what are the practices they follow as far as the role of corticosteroid in the management of bacterial keratitis is concerned? Dr. Santos, your thoughts first.
Professor, as long as there are active infiltrates, I do not give corticosteroids. I only work on antibiotics. Now, I give empiric antibiotics if there are no results of the culture sensitivity yet, but with that which is consistent at least with the gram stain results. Only if I see that there is, and then as the ulcer improves with the empiric treatment or whatever the culture and sensitivity would say as the more specific and targeted treatment, then we continue to monitor the patient for other host-related response that can aggravate the ulcers independent of the infection. Traditionally, I always would follow that until there is full reepithelialization and healing of the edges, wherein I see blunting of the edges, I do not give corticosteroids, Professor. So I give antibiotics. It may be as a monotherapy or as a combination therapy with other antibiotics if they need be. And I will not give corticosteroids until I feel that it is safe. That is when all the edges have blunted and there's full reepithelialization of the ulcer bed. Now, your question is how many? Yeah, Professor.
What percentage of your bacterial keratitis patients receive corticosteroids? Some rough estimate.
I'd say about 20%, Professor, after full treatment of the corneal ulcers, but only after complete treatment when there is reepithelialization and blunting of the edges, and all the other signs have been dulled by the effect of the antibiotics.
Anybody else has any thoughts on their practice on using corticosteroids?
My answer is very similar to Dr. Santos. I would never start steroids in the acute phase or in the early phase. I would only start steroid once there is a frank, clear-cut sign of its healing. That when the epithelial defect is getting smaller, okay, the AC reactions getting less, and or there's frank, you're totally sure that your antibiotic is responding, and it's you want to balance out the effect of the inflammation, then that's the only time I will introduce steroids. Of course, when it's a marginal infiltrate or a marginal ulcer, and these are mostly sterile, I would start steroids quite early. But those that are the central keratitis, wherein there is it's deep and it's with very dense infiltrates, I would hold off till I'm totally sure that I know of its etiology first, because if it's fungal, I will never start steroids, or even acanthamoeba, I will not even start steroids, or even in the early phase of Pseudomonas, I don't start steroids. Now, only when I'm totally sure of what I'm dealing with, and when I'm sure that it's healing, that's the only time I will introduce the steroids.
And what percentage of your patients receive corticosteroids?
If the conditions I mentioned exist, let's say it's totally healing, I know that it's a bacteria, I know that it's not fungal, the antibiotics working, then all the time I will give steroids for all the cases, because it really hastens shortens the redness, and all the problems that comes with it. It hastens the healing.
Okay, so I think let me try to give my thoughts on the use of corticosteroids in the management of microbial keratitis. This topic is controversial and is being studied right from 1952. If you look at this debate that probably is going on as far back as 1952, and in last 70 years probably we have not made any good progress of developing very clear guidelines as to the use of corticosteroids in the management of keratitis. And that is primarily because no one really understands what is the value addition that these steroids bring whenever you treat patient of corneal infection. The rationale for using corticosteroid, as alluded to by the panel, is primarily that the corneal infection basically comprises of infiltration by leukocytes, which then release pro-inflammatory cytokines, including metalloproteases, which then induce additional injury onto the transparent corneal collagens, or the corneal collagens. And therefore, the host response in some way is also perpetuating the ulcerative process. People thought that if we can suppress this host response, we should be able to hasten the healing process after the infection has been brought under control. The use of corticosteroid gained momentum when most of the clinicians realized that the antibiotics that we use in the treatment of corneal infections are bactericidal. So within 48 to 72 hours of starting therapy, which is targeted against the offending microorganism, you are likely to see that these organisms are cleared, or the tissue is cleared of these causative organisms, and therefore the corticosteroid may bring response or may hasten the process of healing by controlling the host response. The expectation from the use of corticosteroids were that its use will reduce the scar size, will improve the visual outcome, and shorten the duration of the disease. These are expectations with which people rationalize the use of corticosteroid. But the question is that, does it really happen? Is the use of corticosteroid truly help reducing scar size, truly help shorten the duration of disease, and improve the outcome? Added to that was a concern that a lobby or the school that was thinking against corticosteroid started arguing that corticosteroid use also prevents conversion of macrophages into fibroblast. That is, it is going to reduce the collagen laying and thereby may lead to complications in the form of corneal perforations. So this question was first attended by Dr. Kirk Wilhelmus from Houston, who tried to pull all the publications on corticosteroid uses for bacterial keratitis and try to understand, can we develop some guideline based on the evidence that is there in the literature. What he found was that patients who have already received corticosteroid therapy or those who were administered corticosteroid in combination with antibiotics, the outcomes were poor. This situation may be in a case of corneal infection for a patient who is receiving corticosteroid for other ocular inflammatory disease. For example, corneal ulcer in a uveitis patient, corneal ulcer in patient of dry eye who are treated with corticosteroid, where the therapy with the steroid is started before even antibacterial treatment is initiated. What he also found that the answer to the question as to what happens when the corticosteroids are started after initiating treatment with antibiotics was not available in the literature. And therefore, he advocated that there should be a study conducted where antibiotic is started, and then after 3 or 4 days, corticosteroids are started. And that was the rationale for the SCUT trial, the steroid for corneal ulcer trial, which was carried out in Arvind Eye Care System, Madurai in India, and Proctor Foundation in California. What were the key outcome measures of this study? The primary outcome measure was the best spectacle corrected visual acuity at 3 months, but the secondary outcomes were best spectacle corrected visual acuity at 3 weeks, infiltrate or scar size at 3 weeks and 3 months, and adverse events including corneal perforations. They also looked at time for reepithelialization. So these were the main outcome measures of the study. What were the key findings? The study, although randomized, very well carried out, and was having enough sample size for its primary and secondary outcomes, did not find any difference between the group that received corticosteroid versus the group that was treated using placebo. That is, the best spectacle corrected visual acuity at 3 months was not different in the two groups. The group also found that use of corticosteroid in the treatment of corneal infection, where the steroid is started after initiating antibacterial therapy, were not associated with increased risk of complication. So corticosteroid therapy did not in any way adversely affected the outcome. The group tried to do subgroup analysis because the primary and secondary outcomes were more or less different. They tried to look at, is there any specific group where the use of corticosteroid may be beneficial? Although the sample size for that kind of an analysis was not large enough, what they found was that patients who present with worse disease, that is worse visual acuity, worse corneal infiltrate, an infiltrate which is large in diameter or the depth, and if the corticosteroids are started early, probably showed a better outcome as compared to those who were treated with placebo. So that was a specific group that they were able to identify, although the study was not powered enough to answer that question. So what were the key conclusions of the SCUT study? The key conclusions were that there is no overall difference in the 3-month visual acuity, scar, or infiltrate size, although there were no major safety concerns. So if you practice prescribing corticosteroid to your patients, you probably can do it with ensuring safety to your patients. The study also made a conclusion that there is a possible role of corticosteroid in the management of cases that present with the worse visual acuity or large infiltrate. However, we need to take that third out, the conclusion, with a pinch of salt, because that was not the purpose of the study. That was not the objective that was set out at the beginning of the study. And the sample size was not powered or not enough to give enough power to this study to draw these conclusions. Subsequently, Cochrane Library did a Cochrane review to find answer to this question, and they also did not find any big difference in the outcome with the use of corticosteroids. So what is the message that we can draw from the study like SCUD and other studies that have been published so far? I think in my view, the corticosteroid do not shorten the duration of the disease. They do not lead to reduction in the scar size, as is a common belief. Probably does not affect the visual acuity. However, there are no safety concerns. There may be some beneficial role in the management of severe corneal ulcer, provided we have started antibiotic therapy before starting corticosteroids. So what is the safest way of starting corticosteroid? If you are an advocate of corticosteroid use in the management of bacterial keratitis, the safe way is to perform microbiology workup so that you know your enemy. Start antibiotics that are effective against the enemy, and when you have observed a response, then at that stage you can start corticosteroid therapy. The same point was highlighted by all the panel members' response as well. They were very categorical that they want to do microbiology workup. They want to know their enemy. They want to start antibiotic, and only when they have demonstrable response on antibiotic therapy that they consider starting corticosteroid. And I think that is probably the best way of starting corticosteroid if you are an advocate of corticosteroid therapy. However, do not expect miracles. Now that brings me to another question, because this question was raised by Dr. Ronaldo, that he will not use corticosteroid in a patient of acanthamoeba. Is there any different opinion about the use of corticosteroid in acanthamoeba? Jessica, what will be your thoughts on this question?
For acanthamoeba, we need anti-inflammatory medications for acanthamoeba, maybe a bit of NSAIDs, but I seldom do not use, I seldom use topical steroids on acanthamoeba as well.
Do you have any specific indication or situation where you may use corticosteroid or never?
I guess if there's really very, very severe inflammatory reaction, and I'm quite covered with anti-acanthamoeba therapy, I may consider use of steroids. But yes, but very, very conservatively.
Is there a difference of opinion on this? Is somebody absolutely against using corticosteroid in a microbiology proven case of acanthamoeba?
All the cases I've seen were all referred, and these patients who were on steroids, they were not diagnosed as acanthamoeba in the first place. They were diagnosed as something else, like herpetic stromal keratitis, etc. So steroids were given, and I found that all these cases really turned out quite bad. Now, almost all of them would we have to do a total graft due to corneal melting and perforation. So if that's the reason why I don't advocate steroids, if it's a frank case of acanthamoeba, because most of the cases we've seen were on steroids and they really have a very poor outcome.
Mm-hmm. So let me try to give my perspective on use of corticosteroids in acanthamoeba. About 2 years earlier, we analyzed about 235 cases of acanthamoeba keratitis that we managed and found close to about 60 patients that were given corticosteroid at some point during the course of their treatment after the diagnosis was made. It is important to understand we are talking of not the use of corticosteroid prior to the diagnosis. I'm talking about use of corticosteroid after the diagnosis has been made, and we found 60 such cases in the search that we carried out. Now, what is the lesson that we learned from these cases? I think the major indications for the use of corticosteroids in microbiology proven acanthamoeba keratitis were where the patient had intolerable pain, where the disease was indolent as characterized by progressive vascularization. You can see on this slide two cases where the cornea is progressively becoming vascularized. If you can see my arrow, I'm pointing out. And if you allow this disease to be treated only on anti-acanthamoeba therapy, this will become almost like what we used to see in the syphilis keratitis. And the third scenario where the corticosteroid were used were patients who developed severe inflammatory reaction either in anterior chamber or on sclera, as seen in this patient who developed scleritis with severe pain. Now, what was the protocol that these people followed? In all these cases, corticosteroid was started only when anti-acanthamoeba therapy has been in place for 2 weeks. The second protocol or second feature that we discovered in these cases was that all of these patients continued to be treated with anti-acanthamoeba therapy while receiving corticosteroid therapy. And the third feature was that these patients, the corticosteroid therapy was stopped when these patients became free of inflammation. But following that, they still continued to receive anti-acanthamoeba treatment for at least 4 weeks after cessation of corticosteroid, at which time they were labeled as cured from acanthamoeba keratitis. So these were the three guidelines that we thought we can advocate whenever a patient requires corticosteroid treatment. A patient of acanthamoeba keratitis requires corticosteroid treatment. Now, I'll just give you a picture of a patient whom we managed last year. This was a 30-year-old young man who received treatment with corticosteroid for suspected HSV keratitis elsewhere for almost a month before he presented to us. When he presented, we suspected acanthamoeba. This was documented on Microbiology Workup as well, and we stopped corticosteroid therapy. Within 3 days, patient developed intense inflammatory reaction in the perilimbal cornea as well as in the conjunctiva, and started developing pain. He soon started showing scleral necrosis or inflammation, at which time we switched him on IV methylprednisolone 3 doses. We still continued him on anti-acanthamoeba treatment. He got relieved of his pain with 3 doses of IV methylprednisolone. And after 2 weeks of anti-acanthamoeba therapy, we started him on topical corticosteroid as well as oral prednisolone. This was the step ladder approach which was published by Dr. Joan Dart, who has done extensive work on the management of acanthamoeba associated scleral inflammation. The patient was also given oral voriconazole as was recommended by him. Now, what is the rationale of oral voriconazole? We really do not understand. But he says that he gave oral voriconazole in all the patients who are being treated with systemic immunosuppression for the management of scleritis. This patient finally responded, the keratitis and the scleritis resolved, and you can see there was extreme thinning of the sclera, and this patient also developed cataract, and we performed cataract surgery on this patient. If there are any question, any clarification on corticosteroid, because I think this is a very important topic, the question from panelists or from the other audience, we will take question at the end of my talk. But if the panelists have any question and want more clarity on the issue of corticosteroid, I'll be happy to pause at this point and try to answer that question. If not,
going back to the case that patient was previously treated with the steroids. So on hindsight, would we just have added anti-amoebic therapy and not stop the steroid that was already the patient was on to prevent the rebound inflammation that was seen in the case? Maybe
so,
yeah.
No, this is a very interesting question because there is a thought that we probably the acanthamoeba keratitis is basically a large part manifestation of the host response. But if we go back to the work Professor Nederkorn in NIH has done, we clearly showed that corticosteroid basically promote pathogenesis by trophozoites of acanthamoeba. And he said that if you continue corticosteroid therapy, you probably are going to make your enemy more and more stronger because corticosteroid help, or they are the food for parasite. So till now, people, the traditional practice has been that as soon as you make the diagnosis, because the use of corticosteroid was for a wrong reason, for the diagnosis of HSV keratitis, which is not the disease that this patient is suffering from. We stop corticosteroid, we give anti-acanthamoeba treatment that leads to flaring up of inflammation, but not all patients becomes so worse. And therefore, in early cases, if you start corticosteroid or if you start anti-acanthamoeba treatment, these patients do very well. And that was very clear because other than those 63 patients, rest all, a majority were treated or received corticosteroid prior to the diagnosis, were subjected to abrupt disruption of corticosteroid therapy. And close to 65% of the patient responded to medical treatment alone. So I'll not worry too much of, or I will not advocate that we should continue corticosteroid therapy. We should rather stop.
Okay, I don't have any other question.
Yeah.
Professor, Dr. Jen Abanya mentioned the use of NSAIDs. What are your thoughts on this before progressing to the use of steroids if you're not very sure whether it's going to be of benefit or not?
So actually, as I showed in my slide also, that we give oral NSAIDs in anti-inflammatory doses if the patient has severe pain or scleral inflammation. And that is roughly about 1 to 1.5 milligram per kilogram body weight of Nepafenec or ibuprofen, that whatever you are giving. So that is much, much higher dose. However, you need to take care of their gastric mucosa when you give such high doses of non-steroidal anti-inflammatory drug. Topical non-steroidal anti-inflammatory therapy is not one which we normally advocate. They give rise to additional toxicity on the ocular surface.
Thank you, Professor.
So let us move on to altogether a very different organism, which is fungal keratitis. Close to about 40% of the cases that we manage at our center are caused by fungi. And filamentous fungi are more common. Candida accounts for only 1% of all fungal isolates. And therefore, netamycin is our first line of treatment. But after the voriconazole was introduced for the management of fungal corneal infection, we also went through the phase where we started debating that if this drug has a very clear solution, has a much higher penetration through cornea, why not we start treating patients with voriconazole? Now, before I give my thoughts, I would like to know what is the first line of treatment for microbiology proven fungal infection in Philippines. Jessica, if you want to give me that, how in Philippines fungal keratitis is treated?
Here we do have natamycin. We also have voriconazole as well. We formulate our own voriconazole, though there's also available voriconazole from your country that is shipped to here. Aside from that, other options would include, sometimes natamycin will be given, the one from natacin from Alcon would be given on a compassionate basis and for some of us.
So how will you treat, say, about this case? Which will be your first line of treatment for the case that you must be seeing on the slide?
Yes. So for me personally, I would, if this is a proven fungal infection, I personally use voriconazole that we reconstitute. Because for the past several years, I've been using it with good results, but I use it with natamycin as well.
Combined?
Yes, combined. Natamycin from India, yeah. And then voriconazole, which we reconstitute. not the one from your country.
Is there anybody in the panel who will have voriconazole as the first line of treatment? Dr. Santos or Ruben?
And then usually the breed.
Yeah, because this the picture shows a plaque, so that would the breedment will be done, and I would just put the patient on natamycin without voriconazole. I mean, voriconazole will come in later in case of there's no response to natamycin, but natamycin will be the first line of my antifungal for this case.
So what percentage of your fungal keratitis cases receive voriconazole, either alone or combination?
My first line is always natamycin. Only when there is poor response to natamycin, so only time I would formulate voriconazole or do a combination with that to add on to the natamycin. But so I only start monotherapy and add voriconazole depending on the response.
Okay. So I think this is another very interesting dilemma. Those of us who were in practice for past 10 years, around 10 years earlier, this whole thing about hype about voriconazole started, where there were a lot of in vitro studies that showed that voriconazole is effective against wide variety of pathogens. They also demonstrated that it penetrates very well through cornea and achieves much higher concentration into aqueous humor. It's a clear solution and therefore does not get deposited onto the ocular surface and less likely to be toxic. So there was a lot of hype that came in, at which point people started asking, is this whole in vitro studies as well as pharmacokinetic study translate into clinical response? And that was the basis of the MUTS trial. Some of the other challenges that are we face in the management of fungal keratitis are that there have been very few studies that have looked at different antifungal agents' efficacy in a comparative clinical trials. Even the Cochrane review could not find a good number of studies that have really compared drug A with drug B that have been used in the management of fungal keratitis. Second question that is now currently being investigated is, are these antifungal drugs, like antibacterial drugs, have specific activity against different fungi? A drug more effective against Fusarium, a drug more effective against even Fusarium solani compared to other Fusarium species, a drug more specific against Aspergillus. So is there a species level variation in the activity of these antifungal drugs? The third problem or the third challenge we have in the management of fungal keratitis is there a value in combining drug A with drug B? For example, natamycin with voriconazole. Does it give superior response? Is there a value in intracorneal or intracameral injection of antifungal drug in the management of keratitis? And there are studies that advocated the benefit from the local injections of the anti-acanthamoeba. As was highlighted by the panelists, that many of us advocate the use of debridement in order to enhance drug penetration as well as debulking. But MUTS trial showed that their limited data was indicating that corneal epithelial debridement was associated with poor visual outcome as compared to those who did not receive debridement. So following that, the debate started whether we should be doing epithelial debridement or not. So let us look at what was the findings of the Cochrane review, and they really could not find drugs that have been used on a comparative basis except natamycin and voriconazole. They could find studies that were done only in India, all the studies that were published so far. What were the findings? That they did not find much difference in the clinical cure between natamycin and voriconazole. The difference was not statistically significant. Same was for the microbiology cure, although patients treated with natamycin showed a much higher number of people becoming culture negative at 1 week. In terms of the best corrected visual acuity, again, there was no difference between natamycin and voriconazole. Same was true with the time to heal. But what was the biggest difference between natamycin and voriconazole was that the rate of adverse reactions was much higher with the use of voriconazole. That is, the number of corneas that developed corneal perforation or required therapeutic keratoplasty was higher in voriconazole treated group compared to natamycin. And the clinical response when they looked at the species variation, they found that the difference was between natamycin and voriconazole was reaching significant level for fusarium keratitis cases. But for aspergillus, the natamycin was equally effective for as voriconazole. So what was the recommendation of this MUTS trial as well as the Cochrane review? That at this point of time, the natamycin is probably the best option in the treatment of filamentous fungal keratitis. However, the Cochrane review did not highlight the point that this superiority of natamycin to voriconazole is much more prevalent or much more relevant for fusarium keratitis rather than aspergillus keratitis. So what we can draw a sense from this evidence is that natamycin and voriconazole are equally effective in the management of filamentous fungal keratitis, with the caveat that when you are treating fusarium keratitis, natamycin should be your preferred choice rather than voriconazole. We also tried to verify the findings of MUT trial, and our study also found that natamycin was superior to voriconazole. The epidemiology of the fungal infection in both the places is almost the same, and therefore this was expected outcome of the study that was conducted. The second aspect in the fungal keratitis is there a value in combining different antifungal drugs? As Jessica told, that we combine natamycin with voriconazole. Their earlier studies were suggestive that the concurrent use of antifungal drugs does not offer any additional benefit. But that study was done in combining natamycin with voriconazole. However, another study was conducted from our Indian colleagues in All India Institute of Medical Sciences, the team led by Dr. Namrata Sharma, who showed that topical voriconazole seems to be a useful adjunct to natamycin in fungal keratitis, particularly those who are not responding to natamycin monotherapy. They also looked into the role of intracorneal injection, and they published 2 studies. Their earlier study was on a 12 cases, which was published in British Journal of Ophthalmology, where the intracorneal injections were given to patients who did not respond to topical antifungal therapy. And they found that they were able to cure infection in those patients which were otherwise not responding with the addition of intracorneal injections. However, in another study where they were trying to compare the efficacy of giving voriconazole as topical drop versus intracorneal injection, they found that combining topical voriconazole was as effective as topical and intracorneal injection, and they suggested that as a first response for a patient who is not responding to monotherapy with natamycin, we can consider adding topical voriconazole rather than switching over to intracorneal injection of voriconazole. What is our practice? We use intrastromal injection in patients who have central lesion with enough clear margin so that you can monitor the response to therapy. If the patient has advanced keratitis or is threatening, where the infiltrate is threatening to involve limbus, we rather prefer to go for an early surgery rather than treating them on medical management. So to conclude about the controversy around fungal keratitis, what we can safely say is that natamycin and voriconazole are equally effective. However, if you are treating a case of fusarium keratitis, the preference should be toward natamycin rather than voriconazole. For patients who are not responding to monotherapy, you can consider combining natamycin with voriconazole. That may offer some advantage or may give them some adjunctive treatment in the form of intracameral or intracorneal injections. Any question related to fungal keratitis controversies? I'd like to pause at this point of time and then take those questions before we go on to another controversial issue of collagen cross-linking in the management of corneal infection.
Professor, how about the role of corneal transplant in fungal keratitis or unresponsive to medications?
Yeah, so I'll touch that point after collagen cross-linking, and we'll give you what is our practice as far as corneal transplant is concerned.
Thank you.
Any other question related to medical management?
Yeah, I was just thinking, Professor, what are your thoughts on the role of adding oral antifungals for cases that are not very responsive to the topical medication?
So we give oral antifungal therapy in patients who are presenting with the posterior stromal involvement and those where the lesion is closer to sclera. Very recent study published by, again, the group in All India Institute of Medical Sciences also found that oral antifungal therapy, specifically the voriconazole, may be effective in recalcitrant corneal infections. So they are saying that if you have severe corneal infection, then we can consider giving oral antifungal therapy.
Is there a favorite one of yours, Professor, among the oral preparations you use?
So my preference is basically is for itraconazole. However, the cost implication of voriconazole and itraconazole limit the use of these drugs, and therefore we end up using ketoconazole. The main problem with the ketoconazole is that it is toxic, and therefore we need to monitor a liver function test in every patient who is receiving these drugs, which holds true even for voriconazole and itraconazole. But I think the hepatotoxicity is much more common with the ketoconazole. So I think there are two questions on the chat. In areas where natamycin and voriconazole are not available, do you suggest fortified antifungals? If yes, how do you prepare it? So we currently are not giving any other drug. Most of the patients get response from natamycin and voriconazole, both of which are available. However, earlier we used to prepare drops from amphotericin B. The amphotericin B drop need to be replenished every second or third day because they lose their efficacy after 48 to 72 hours. Number two, they are very toxic. The conjunctiva and the lid can become very inflamed when you treat these patients with amphotericin B. And the cost of treatment becomes much, much higher because you cannot store those vials for long that you have reconstituted from the parental operation. So because of those reasons, our preference is more for. How about fluconazole? We have looked at the in vitro susceptibility. of fluconazole, and we did not find that fluconazole is effective against wide variety. But if we do not have natamycin or voriconazole, we probably can consider giving fluconazole. But I'd like to hear from you what has been the response with the use of fluconazole, because our experience is limited. How about the role of amphotericin B? I have already alluded to the amphotericin B. I'm currently working with a group in UK formulating amphotericin B, which probably can be dispensed as eye drop. We have made some progress in that, but we are a long way before that will be available commercially. I have also worked on microneedle patch with amphotericin B incorporation, and in the mouse model of fungal infection, we found very good response with the microneedle patch. That patch you apply onto the infected cornea, it releases all the amphotericin B that we load, and then that lead to a good response. So I'm very optimistic that amphotericin B is a very effective drug. However, we do not have a good formulation, and probably there is a need to do research on bringing out the commercial formulation of amphotericin B. So let us go to the another interesting topic, which is collagen cross-linking. I do not know what are the practices in Philippines. Do people use collagen cross-linking in the management of microbial keratitis? Dr. Santos or Jessica?
I have not had the chance to use collagen cross-linking for my patients with microbial keratitis. I don't know if, because it's a bit expensive here. So, and I don't know if, because most of these instruments are in the LASIK centers. So I don't know if, yeah.
Has anybody used
Yes.
it? Yeah.
At the Philippine General Hospital, we have a collagen cross-linking machine. And a resident of mine did a very, very small comparative trial with continuing with standard therapy. One group received collagen cross-linking. Now, based on the results of a very limited sample size, it shows us no significant effect compared to those without cross-linking.
So will you recommend?
I don't recommend. Well, personally, I don't. I don't think no one is really using collagen cross-linking here as part of the management of microbial keratitis.
Okay, I think that answers, or that is the same as my view is. I think, but the basis for the use of collagen cross-linking in the management of corneal infection was primarily because of the anti-infective properties of the ultraviolet A, as well as photoactivation of riboflavin, which causes damage to the bacterial or the microbial RNA, DNA, and cell wall. In addition, people thought that if this strategy, in addition, result in a strengthening of corneal collagen, then the risk of corneal perforation will be low. The organisms will be restricted from entering into the deeper corneal stroma, and thereby the disease will be limited. Further, to support the use of collagen cross-linking were the arguments that the technology is used for inactivation of viruses and bacteria, parasites in various industries, including sterilization of water and blood products. But while there may be a lot of rationale for using this therapy, do these rationale translate into experimental or clinical benefit? Were the questions that were that were put forth by the scientist. Initially, a lot of experiments were carried out on in vitro activity of photoactivation of riboflavin, trying to understand how organisms respond on the culture plate. We also did a small pilot of response to collagen cross-linking on organisms on the culture plate, and found that other than drug-susceptible bacteria, the collagen cross-linking did not inhibit the growth of bacteria on culture plate, bacteria, fungi, and parasites. In terms of clinical efficiency, most of the published literature is in the form of case report or case series. There are only a couple of case control studies and only one prospective comparative clinical trial. Now, the randomized prospective clinical trial was published in 2014, where 40 patients were enrolled, 21 were randomized to collagen cross-linking and antimicrobial therapy, and remaining were randomized into antimicrobial treatment alone. The study did not find any difference in the outcome of the two groups of patients, although there were no difference in the complications as well. This study was questioned by people who were advocating the use of collagen cross-linking because there was difference in the size of infiltrate in the two groups, and the perforations were seen mostly in the control group. They were not seen in the collagen cross-linking treated group. So they said that the authors have overlooked the benefit that collagen cross-linking offers. Let us look at some of the other evidences that were in favor of collagen cross-linking or against collagen cross-linking. This is a study which was conducted by Price and group published in 2012. It was a non-comparative case series. 40 patients were enrolled. They enrolled patients of bacterial etiology where the infiltrate size was 2.5 or less, which showed faster recovery. Fungal and acanthamoeba cases in their series responded poorly, and they said that if at all we are advocating collagen cross-linking, it should be for an early disease and of bacterial etiology. Another study which was published from India in 2015, which tried to look at fungal use of collagen cross-linking for fungal keratitis, because they thought bacterial keratitis management is not really a big problem. And they enrolled 20 cases, but they did not find much response in the healing time, and the study was stopped before they completed the enrollment. Another study enrolled 16 patients. 14 did not require any antibiotic treatment, and they all got resolved on collagen cross-linking. This study advocated that collagen cross-linking can be the primary treatment in an early case of keratitis. Realizing that there is a variety of data that is available on collagen cross-linking, Alio group published this meta-analysis of collagen cross-linking, and they found that if you combine all the series, that probably suggests that bacterial keratitis cases may benefit from the collagen cross-linking, but acanthamoeba and fungal keratitis cases do not do well when treated with collagen cross-linking. So today we do not have very good evidence to support the use of collagen cross-linking using Dresden protocol. However, there is another group that is working very actively on studying phototherapy for the management of microbial keratitis. They are using sodium fluorescein and try to and leishmanian green photoactivation. This group is in Bascom Palmer Eye Institute. They have published few case reports on beneficial effect of collagen cross-linking in acanthamoeba and more recently in fungal corneal infection. So probably other protocols may offer more benefit rather than the protocol that is currently being used in the treatment of keratoconus. And we still are looking forward to the progress that is going to be made in the field of phototherapy for the treatment of corneal infections. Let me come to the last part of my talk, which is related to the surgical management. Now, on this slide, you are seeing three different case scenario. One where the cornea is extremely thin, and you see there is an ectasia, so almost like desmetocele with extreme necrosis of the cornea. In the second case, there is an advanced acanthamoeba keratitis. And the third case is where the patient had advanced fungal keratitis. I think before I proceed, I like to know what will be the preferred surgical management in Philippines. If any of the panel member will like to address that question. What will be the preferred surgical procedure for these cases of microbial keratitis? Ruben, if
Okay.
I can
I'm
take
here.
our help.
Okay, so well, if the cornea is perforated, there is really no choice, but you have to do a full penetrating keratoplasty. If and then looking at the pictures, now the first and the last one really would need these are, if it's cornea is melted, definitely it's penetrating keratoplasty. Or it's a very, very advanced or very large, where the whole cornea is involved, then you have to really do an oversized, sometimes a corneoscleral keratoplasty. Now, if it's just in the stroma, wherein you can still do a good lamellar keratoplasty, sometimes we would attempt to do a lamellar keratoplasty if that is possible, but majority of our cases would end up with a large penetrating keratoplasty, because most of them are far advanced and a lot of them are perforated.
What's your thought on lamellar keratoplasty for fungal keratitis?
It's maybe for fungal, maybe because it's very our recurrence rate is high. So even if it's a penetrating keratoplasty, so it's really can't really tell if you could remove all the fungal elements from the cornea. So if you do a lamellar, you will have to make sure that you continue your antifungal therapy and hope that there is no recurrence. So that's the downside of doing lamellar in fungal keratitis. I would rather do lamellar more in a clear-cut case of bacterial keratitis rather than a fungal keratitis.
And for acanthamoeba?
For acanthamoeba, again, here you don't know the extent of the, it's hard to tell until where the amoeba have gone. So maybe, again, choosing between lamellar or penetrating, I would do a penetrating more in case of acanthamoeba, because again, you can't tell on the table where the cysts are located, so you really want to remove as much as you can.
So I think there are a lot of reports about the benefit of doing deep lamellar keratoplasty over penetrating keratoplasty in management of advanced infectious keratitis, particularly the Singapore group and the Chinese authors have advocated very strongly about the use of DALC in the management of active microbial keratitis. And they have documented that the outcome, particularly in terms of graft survival, is superior using DALC. However, the procedure is challenging, number one, and many times we end up doing full thickness graft because of the perforation on the operating table. Further, the use of lamellar keratoplasty for mycotic keratitis was the question that we um, asked. We wrote a letter to editor in response to this paper that was published from the Psy group, where they had very good outcome doing lamellar keratoplasty. However, most of these cases were very early with this very superficial infiltrate, and probably keratectomy itself would have removed a lot of fungal filaments. So what we thought is that let us look at our own data of corneal buttons that have been removed during full thickness graft and try to see where fungal filaments are located. And our data, which was published in 2003 in Ophthalmology, showed that in close to about 50% of the cases, fungal filaments were seen very close to the descemet membrane and even penetrating descemet's membrane. So we designed another study where all the patients of fungal keratitis, which are undergoing therapeutic graft for advanced keratitis, were enrolled. Those with corneal perforation were excluded. And what we did is that we modified the surgical procedure whereby we first removed superficial 2/3 of the cornea, and then the deeper block was removed. So the patient proceeded with penetrating keratoplasty, but the deeper block was subjected to histopathology. Now, this deeper block histopathology again showed that in close to 60% of the patient, deeper block was infiltrated with fungal filaments. And in many of these patients, the fungal filaments were seen penetrating descemet's membrane. Following this observation, we made following recommendation as far as the use of DALK is concerned. We advocate DALK in non-perforated cases of bacterial keratitis, non-perforated cases of acanthamoeba keratitis, but we do not advocate DALK for fungal keratitis. And the same was experienced with the microsporidial keratitis. We did it in 2 cases, and in both the cases, there was recurrence. We looked at the histopathology and we found that microsporidia were all concentrated near descemet's membrane, although the infiltrate was more anterior. So based on these observations, for patients that are requiring surgery, our preference will be for penetrating keratoplasty, specifically for fungal and microsporidial. DALK is reserved for bacterial and acanthamoeba keratitis. So to conclude this session, I think we discussed several issues related to corneal infection where there is no clear-cut opinion. We first talked about empirical versus culture-guided treatment. We talked about monotherapy versus combination therapy in the management of bacterial keratitis. We discussed the role of corticosteroid, and we then touched upon issues such as voriconazole versus natamycin, collagen cross-linking, and DALK versus full thickness penetrating graft. It was a pleasure to speak to you and share my views, although I overshot my time that was allotted. But I think it is always a pleasure to share these different topics, which probably will be relevant to ophthalmologists in your country as well. Thank you once again for making me part of your ongoing lockdown learning series and these lecture series.
We'd like to thank Professor Prashant for the wonderful lecture. I think, if there are any other questions that the coming in from the live streaming in Facebook, I think we have some guests all the way from other countries too. We have one of our graduates, Lizelle de la Paz, who's on board, who's based in Barcelona. Welcome, Lizelle. And are there questions maybe coming in from other groups? Yeah. maybe we'd like to hear from Dr. Jack Diliacos, one of the panel of reactors. Sir, would you have some questions or comments on or thoughts on the lecture of Professor Prashant, Dr. Jack Diliacos?
Well, I think the professor has actually covered extensively microbial keratitis. And of course, I was hoping he would also have touched on herpes simplex virus keratitis, which is, again, probably would be presenting a lot of controversies as far as its management. But maybe that would be a subject for another session with him in the future. And well, for acanthamoeba keratitis, I usually do not do keratoplasty right away. It's been, studies have shown that you have to wait 1 year for everything to quiet down, for everything to heal, because there may still be some parasites within the stroma of the cornea. So if you're sure that everything has quieted down, then that would be the best time to do the penetrating keratoplasty, or maybe, for that matter, Lamellar. Now, why again does fungus penetrates the desmase? Well, compared to bacteria, bacteria does not have an enzyme to penetrate desmase. It stops at desmase. That's why most bacterial ulcer would produce desmetocele. Whereas with fungal keratitis, it will only take a few weeks for it to travel deep down into the stroma and penetrate the desmase. That's why if you see already a lot of hypopion, most probably they are already in the anterior chamber. So as what Dr. Prashant has mentioned, this is where you have to do penetrating rather than lamellar. Like, maybe I'd like to question Professor Prashant, if in case you have an impending perforation, how do you approach it?
So if the perforation is less than millimeter in size, then we usually put tissue adhesive and then continue medical management. Or if there is a large perforation, then we usually go for full thickness penetrating keratoplasty. We make sure that we are excising as much as possible the diseased cornea and then leave behind the healthy rim. What is more important in the management of these cases is what kind of post-operative treatment are you going to be giving to these patients. For bacterial keratitis, the management is more straightforward. You continue them on antibacterial therapy and will be able to start corticosteroid immediately if you know they are enemy. However, in fungal keratitis, corticosteroid therapy is deferred for close to 3 weeks. And this 3-week cutoff point we have drawn from our retrospective study on looking at recurrence of infection. And we found that recurrence of infection in these patients occur mostly within first 2 weeks. Close to 93% of the recurrences in a large series of 350 patients, we found that happens within 2 weeks. So if there has been no recurrence in first 3 weeks, then you probably have eradicated infection and you can safely start corticosteroid.
Professor?
Yeah, go ahead.
My question actually, sorry to interrupt, but my question is, what do you do for impending perforations? It has not yet perforated. Let's say you're dealing with an active infection with maybe a starting desmetocele. So how do you prevent perforation from happening?
Yeah, for those cases, we just put the tissue adhesive over the desmetocele area and then continue the antimicrobial treatment. I don't know whether I have understood your question very well, but the desmetocele is relatively easier unless it is a very large desmetocele. In those cases, we have attempted DALC, but we most of the time end up having perforation. So the preferred surgery will be penetrating keratoplasty if we are taking them for surgery. But if the lesion is small and there is only desmetocele, tissue adhesive works very well. And we published our work in 2002 in journal Cornea, where we showed that despite presence of tissue adhesive, 67% of the fungal keratitis patients who were managed, who developed desmetocele and were managed with tissue adhesive, we were able to cure the infection. Because the fear is, if you put tissue adhesive and put bandage contact lens, the drug may not enter into the corneal stroma.
Okay. Thank you, Professor.
Does that answer your question?
Yes, thank you.
Okay. So one of the question from the Facebook is that based on the histopathology, would we recommend an early intracorneal injection? And I think, as I told you, that intracorneal injection is advocated for patients who have central infiltrate and where there is enough clear margin, because then you can assess the response to your treatment. But if you are dealing with a patient with a posterior stromal disease, where the infiltrate is encroaching toward limbus, or a posterior stromal disease where there is extensive corneal thinning and likelihood of perforation, no point in waiting with intracorneal injection. In another 2-3 days, they may require surgery, and therefore it is better to take them for surgery early rather than treat them with intracorneal injection. So we have very, very strict guideline as far as the intracorneal injection is concerned. There is another question on use of medoxyprogesterone in infectious keratitis with melt and immediate post-operative penetrating keratoplasty. I do not have much experience with medoxyprogesterone. It's an anti-inflammatory managed therapy, and probably may have some role, but whether they will be successful in preventing melt, I probably will not be able to answer that question. We use doxycycline in patients who are showing active melt, but our mainstay of treatment will be to prevent ingress of leukocytes. So in a progressive melt case, we apply tissue adhesive, which prevent ingress of leukocyte and thereby provide not only tectonic support, but prevent subsequent melt from the mediators that are released from. Do you perform anterior vitrectomy and lensectomy when you do PK? Not in every case. If there are fungal or if there are infiltrate in the retro-iris space, then that indicates that this patient has, the infection has gone into the vitreous cavity. In those cases, we do the lensectomy and vitrectomy. So it is entirely based on your intra-operative observation. Do you give vitamin C? Not really. I'm not very strong advocate of vitamin C, except in patients who are developing melt following chemical injury. If you are talking about that, then probably that's a specific entity where we give vitamin C, but not in patients with microbial keratitis. Looks like there are no more questions.
Ray, you have to unmute. Ray, unmute.
We'd like to call in Dr. David Dwala, who's the Vice President of the Philippine Society, to host the session.
All right, so I guess that concludes our talk for this afternoon. I'd like to thank all of you who joined us and participated in this special and relevant talk. we are very, very grateful to Professor Garg for giving us this wonderful lecture. I was very, very captivated about this whole time and learned so much. And I'm sure all the cornea specialists and even those who are not learned so much today from your input, Professor Garg. Thank you very much.
Thank you.
I'd like to thank the Philippine Academy of Ophthalmology for organizing this lockdown lecture with the Philippine Cornea Society. And we look forward to providing you, Philippine ophthalmologists, more of these talks in the near future. And with that, we'd like to sign out. Thank you very much to everyone.
Thank you.
Thank you very much.
Thank
It
you,
was a
Prof.
pleasure.
Thank you. Thank you very much.
Thank you very much, Professor Prashant.
Thank you, Dr. Garg. Thank you.